Good afternoon, respected teachers and my co-PGs. Good afternoon, respected teachers and my co-PGs. I'm going to start my journal club on medication-related osteonecrosis of the jaw. Now, osteonecrosis is also known as a vascular necrosis of the bone, and it is a degenerative condition of bone which is caused by the reduced blood supply. This occurs due to direct tissue toxicity, which may result from chemotherapy, radiotherapy, thermal injury, or smoking. In the 18th century, there was a term phossy jaw, which was described for the osteonecrosis of the jaw among workers exposed to the phosphorus vapors. With the emergence of bisphosphonates, the prevalence of osteoradionecrosis of the jaw was noticed among bisphosphonates users, which was again termed to bisphosphonate-related osteonecrosis of the jaw. This was again renamed to medication-related osteonecrosis of the jaw by a special committee formed by the American Association of the Oral and the Maxillofacial Surgeons. Now, they published a journal in 2014, and it said the patient who are undergoing any anti-resorptive or anti-angiogenic drugs, they may have exposed bone or fistula, and the bone can be proved for more than 8 weeks, and if there is a negative history of radiation therapy, then it gives rise to the medication-related osteoradionecrosis of the jaw. Other systemic and local factors that give rise to this condition is diabetes, anemia, dentoalveolar surgical procedures, extraction, implant placement, periodontal surgeries, infectious dental diseases. Now, the medication-related osteoradionecrosis of the jaw can be preventable with many evident studies showing that any invasive procedure required in dentomaxillomandibular region should be performed 2 to 3 weeks before any anti-resorptive or anti-angiogenic medication. The management can be surgical or non-surgical with any adjuvant therapy like laser-assisted debridement, platelet-rich plasma, platelet-derived growth factors. They give good results. Now, the etiology and the risk factors. The anti-resorptive therapy is usually the management for osteoporosis, hypercalcemia-related metastatic malignancy, and multiple myeloma. These groups of drugs include the BP or the biphosphonates and the rank ligand inhibitors, which is also known as the receptor activator of nuclear factor kappa ligand, which includes denosumab. The most commonly used bisphosphonates are the zoledronic acid that is usually given intravascularly and palidronate. The risk of developing the medication-related osteonecrosis of the jaw in biphosphonates users depend on the type of the drugs, its various stages, duration of the treatment, routine of administration, along with the presence of other systemic and local conditions. Studies have also reported that the risk of developing this osteoradionecrosis is higher in cases with intravenous administration of bisphosphonates, that is usually zoledronic acid. Also, cancer patient having a higher risk of this osteoradionecrosis in comparison with the patient with osteoporosis. Now, this receptor activator of nuclear factor kappa ligand inhibits the denosumab, which is very effective in minimizing bone loss associated with breast and prostate cancers, menopause, osteoporosis, and giant cell tumor. Now, angiogenesis. This is a cycle describing the angiogenesis. Angiogenesis is a process that involves the growth, migration, and differentiation of the endothelial cells, which forms the new blood vessels. Now, anti-angiogenic drugs are used in the management of malignancies involving ovary, metastatic renal cell cancer, breast cancer, colorectal cancer, non-small cell lung cancer, and glioblastoma multiforme. The anti-angiogenic medication administered with anti-resorptive medication has a significant association between the duration of exposure and the development of this medication-related osteoradionecrosis of the jaw. Now, the long-term use of systemic administration of steroids increases the risk of these necrosis, and the most common sites that are involved are the femur, tibia, humerus, calcaneus or scaphoid bones. Corticosteroids along with does not do this alone, but it sometimes when it is administered with biphosphonates or denosumab, or that is the rank, could have an increased risk of developing this type of osteoradionecrosis. Corticosteroids, when various drugs like methotrexate give rise to this medication related osteoradionecrosis of the jaw. Now, what is methotrexate? It is a cytotoxic medication indicated in the treatment of a number of solid tumors, hematological malignancies, and rheumatoid arthritis. Beside these medications, other systemic and local risk factor in the development of these diseases are diabetes and anemia. There are various literatures supporting this positive correlation between this osteoradionecrosis related to medication and tooth extraction, also dentoalveolar infections. Now, there are the pathogenesis of this osteoradionecrosis, which usually occurs because of the medication. There are almost 3 pathogenesis: bone remodeling inhibition, inflammation or infection, and soft tissue toxicity. Now, the pathophysiology of the disease is not exactly known, but there are various hypotheses related to this, and these are available in the literature. This hypothesis attempts to explain the exclusive occurrence of these osteoradionecrosis of the jaw. The first one is the bone remodeling inhibition, which is considered as one of the pathogenesis, and it is a highly complex process by which the old bone is replaced by the new bones. This process includes 3 phases: bone resorption, transition, and bone formation, which is achieved by the coordinated actions of the osteoblast, osteocytes, osteoclast, and other bone lining cells. The receptor activator of nuclear factor kappa ligand, or the RANKL, plays a very crucial role in osteoclast formation. It is secreted by the osteoclast, osteocyte, and bone stromal cells. It includes the osteoclast formation by binding to a receptor on the osteoclast precursor. Now, this is the entire process in which the radiation affects the body and causes this osteoradionecrosis. It affects directly and indirectly. It can affect directly to the bone cell and causes the death of the bone tissue cell and causes hypocellularity. This further leads to tissue breakdown and causes osteoradionecrosis. In other ways, it acts irreversibly by changing the cell's functions, and it damages the osteoblast, osteoclast, fibroblast, and there is a loss in the reparative and synthetic function leading to osteoradionecrosis. Also can cause vascular damage, causes endarteritis obliterans and thrombosis of the vessels, which leads to hypovascularity and leads to ischemia and hypoxia, which again give rise to the osteoradionecrosis. Bisphosphonates and other anti-resorptive drugs inhibit the osteoclast function, differentiation, and increase apoptosis of osteoclast, all leading to decreased bone remodeling. Bisphosphonates have a strong affinity for hydroxyapatite because it gets accumulated into the bone matrix and is retained there for a longer time. Now, when this deposits, this get again incorporated into the osteoclast through transcytosis during the resorption process, leading to impaired function of the osteoclast. Now, RANKL is produced by osteoblast and mesenchymal cells and is one of the most important cytokines regulating the differentiation function and survival of the osteoclast. Thus, by inhibiting this receptor activator of nuclear factor kappa ligand, denosumab inhibits the differentiation of osteoclast, leads to decreasing the resorption of the bone. This is a picture, this is an image showing how the bisphosphonates denosumab, which comes under the rank L category, and cathepsin K inhibitors in this influences the bone. The bisphosphonates bind to the bone mineral nitrogen containing bisphosphonates, which inhibits the resorptive function of the osteoclast via inhibition of the FPPS and prenylation of the GTPase, but disabled osteoclast may persist. The denosumab, which is also the rank L, it binds to the rank L and receptor and blocks the osteoclast differentiation and reduces the osteoclast numbers to almost zero. And cathepsin K inhibitors, it persists the presence of cathepsin K inhibitors and may continue to produce the clastokines that stimulates the osteoblast. Osteoclast differentiation and function may play vital roles in bone healing and remodeling at all skeletal sites, but osteonecrosis may occur in the alveolar bone of the jaw. The alveolar bone may demonstrate an increased remodeling rate as compared to other bones of the skeleton, but it is not a proven fact. Now this was the first pathophysiology. Here we see the anti-resorptive drugs. The anti-resorptive drugs, they causes two things. They causes the osteoclast differentiation as well as the activation frequency. Now both of these things causes the bone remodeling, and it works in three different ways, like mineralization, preventive microstructuralization, and positive EMV structures. All these things give rise to or decrease the effect of fractures in an individual and thus acts. Now the second pathophysiology is inflammation or infection. It is in most of the literature available, tooth extraction was followed by the osteoradionecrosis of the jaw. These teeth commonly had a pre-existing periodontal or periapical disease and pus discharge. Jawbone, which is covered by a very thin layer of mucosa, and also the presence of more than 800 species of bacteria, make jawbone more susceptible to osteoradionecrosis as compared to other bones. Inflammation, infection often occurs after the extraction of the teeth with advanced dental disease or around teeth with periodontal or periapical infection. Anti-angiogenic therapies that are now widely utilized to inhibit the tumor invasion and metastasis targeting vascular signaling molecules. Osteoradionecrosis is classically considered as an interruption in the vascular supply, or it is also a avascular necrosis, and therefore it is not surprising that inhibition of angiogenesis is a leading hypothesis in osteoradionecrosis of the jaw physiology. The third hypothesis or the third thing is that the soft tissue toxicity and innate or acquired immunity dysfunction. The bisphosphonates, they bind to the hydroxyapatite, as I have already told, in bone. During the resorption process, it gets incorporated in the osteoclast. Now this has been reported that with bisphosphonates but not associated with denosumab, which is a rank L enzyme. Tumor pathogenesis is often associated with an impaired immune function. All the pathogenesis suggests that the underlying mechanism of this developing medication related osteoradionecrosis of the jaw is probably multifactorial. There are also various genes involved in this pathogenesis. In patients having multiple myeloma, CYP28 and vascular endothelial growth factor is associated with the development of these disease treated with bisphosphonates. CYP2C8 is a drug metabolizing enzyme that presents on the chromosome 10q24. It is not involved in the metabolism of bisphosphonates, but it may affect the differentiation of osteoclast by mediating cholesterol synthesis by the HMG-CoA pathway. PPARG is located on the chromosome 3 band 3p25 and is involved in regulating the glucose utilization and adipocyte differentiation, inhibiting inflammatory signaling and mediating bone hemostasis. The growth factor VEGF regulates the angiogenesis and thus contribute to the important roles towards the osteogenesis. Now come to the treatment modalities. It can be treated in various ways, like the conservative treatment, surgical treatment, laser assisted treatment, and the PRP or PGDF, plasma derived growth factor treatment. Now the treatment, conservative treatment or the non-surgical treatment includes the antimicrobial mouth rinse, that is 0.2% chlorhexidine digluconate, local cleaning of exposed bone and fistula, pain control, and the systematic antibiotic and nutritional support. We can also prescribe broad spectrum antibiotics which include amoxicillin, clavulanic acid, ampicillin or sulbactam, metronidazole or clindamycin. These are the first line drugs to be used but can be used in combination with other drugs like erythromycin, ciprofloxacin and doxycycline. Also, we can prescribe oral pentoxifylline and tocopherol, which is vitamin E, in combination with antimicrobial therapy, which improves the healing by improving the blood supply and its antioxidant properties respectively. Other treatment are the hyperbaric oxygen therapy, topical ozone therapy, and low intensity laser therapy to improve healing. The low intensity laser therapy has been shown to be effective management as it reduces the pain, improves healing, facilitates the nerve regeneration, and stimulates the reepithelialization, provide antimicrobial properties. The most important laser used is the argon, carbon dioxide, and helium. Now, the main aim of the conservative treatment is to provide symptomatic relief and improving the stages. Now, the improvement in the necrotic bone cannot be expected through conservative treatment alone unless the necrotic bone is removed. Thus, surgical procedures are done. Now, the surgical procedures involves the conservative debridement of the bone as well as the complete resection of the bone. It has been offered mainly to patients with advanced diseases which doesn't respond to any medical treatment. Additional measures such as the use of the plasma related platelet-rich fibrin, laser and drug holiday are also promising adjuvant therapies. The outcome of the surgical treatment is better than the non-surgical treatment. Also, we can summarize the management part into two things, non-surgical and surgical. Non-surgical parts includes the pharmacological part, which includes all the antibiotics, all the analgesics, also some combination therapy, and the pharmacological part includes the local wound care or any hyperbaric therapy, ultrasound therapy, electrotherapy or any ozone therapy. And the surgical part include the sequestrectomy, any resection of the continued defects, reconstruction or rehabilitation of the wound. This was a summary of the management. Now come to cross-reference 1. Medications related osteonecrosis of the jaw, clinical and practical guidelines. This is a tabulation showing the medications, is indication and the trade name available in the market. The category is bisphosphonates, which is indicated in osteoporosis. Then the humanized monoclonal antibody, which is indicated in metastatic colorectal carcinoma, non-squamous non-small cell lung carcinoma, glioblastoma, metastatic renal cell carcinoma, and is available in the trade name Avastin. The third category is receptor activator of nuclear factor kappa B ligand inhibitors, which is also known as rank L, which is indicated in the bone metastasis osteoporosis, and it has a trade name of Xeva and Prolia. Third category is bisphosphonates. There are different stages or the different components of bisphosphonates. So the first, some of are used in osteoporosis, some are used in osteogenesis imperfecta and Paget's disease and different diseases of the bone. The first one is used in osteoporosis and we can get in a trade name of Boniva. The second category is bisphosphonates, which can be prescribed for osteogenesis imperfecta, Paget's disease of the bone, and is available in the trade name of Nerixia. There are other various variants of bisphosphonates which can be used for bone metastasis and also for osteoporosis, and available in the trade name of Iridia and Ectonil. The other variants are tyrosine kinase inhibitors, which is indicated in cases of hepatocellular carcinoma, renal cell carcinoma, and available in the trade name of Nexavar. Another variant of tyrosine kinase inhibitor is indicated in cases of gastrointestinal stromal tumor, renal cell carcinoma, pancreatic neuroendocrine tumor, and available in the trade name of Sutent. Again, there are various other variants of bisphosphonate, which are indicated in the Paget's disease of bone and available in the trade name of Skelet, and some other are indicated for bone metastasis osteoporosis and available in the trade name of Zometa and reclassed. Now the various risk factors of medication related osteonecrosis of the jaw. There are various risk factors like the patient related risk factors, tumor related risk factors, treatment related risk factors, and various miscellaneous factors. Along with that, there are some medication related risk factors, which includes the molecule of the medication, way of administration or the route of administration, the total amount of medication prescribed, and the length of the therapy. The various systemic and other risk factors includes the diseases, which includes the concurrent pathologies, diabetes, rheumatoid arthritis, dialysis, anemia, hypocalcemia, immunosuppression, osteomalacia, and various local factors related risk factors, which includes microtrauma. Some other systemic factors include genetic factors, age, adipotic factors, obesity, tobacco, sex, steroid therapy, and alcohol. And other various local factors include the inflammatory diseases, oral surgery, removable prostheses, anatomic conditions, and oral implantology. Also, there are various some patient-related factors, which include the genders, the age, the race. Various specific tumors related factors like which includes the site of the tumors, the histopathology of the tumor, the staging of the tumor, and the size of the tumor. Also, various treatment related factors are also risk factors is seen, like the radiotherapy setting, the radiotherapy modality, radiotherapy dose, some cryotherapy or surgery. So these were all the risk factors related to the medication related osteonecrosis of the jaw. Now come to the cross reference 2, which gives the maxillofacial osteoradionecrosis, which gives the definitions of the osteonecrosis, which was changed in the evolution or in the following years. In 1983, Marx gave the definition as an area of exposed bone greater than 1 cm in a field of irradiation that had failed to show any evidence of healing for at least 6 months. It was again renewed in 1983 by Beumer, Harrison, and Sanders. An exposure of the bone of the maxilla or mandible within the radiation treatment volume persisting for more than 3 months or longer. In 1986, it was again given by Morton and Simpson, a loss of soft tissue integrity and exposure of radiation damaged bone. 1987, given by Epstein et al., an ulceration or necrosis of the mucous membrane in the absence of recurrent or metastatic disease with exposure of necrotic bone for more than 3 months. In 1939, by Widmark et al., a non-healing mucus or cutaneous ulcer with denuded bone lasting for more than 3 months. In 1990, by Coca et al., a persistent ulceration with exposure of devitalized bone, cellulitis, fistula, and a pathologic mandibular fracture, patients tumor-free at primary site. 1992, Harris, exposed and necrotic bone associated with ulcerated or necrotic surrounding soft tissue which persists for greater 3 months in an area that had been previously irradiated, not caused by any recurrences. In 1993, Mirente and Orton et al., a loss of viable bone resulting from radiation therapy, and the latest one by 1995 by Van Markenstein, Baker et al., a bone or a soft tissue necrosis of 6-month duration, excluding radiation-induced periodontal breakdown. Now the classification of osteoradionecrosis, there were 2 classifications. According to Kagan and Swas staging 2002, there were 3 stages. The first one was stage 1, which included the minimal soft tissue ulceration and limited exposed cortical bone. Stage 2 has 2 subdivisions, stage 2A, stage 2B. Stage 2A, stage 2, localized involvement of the mandibular cortex and underlying medullary bone, which includes stage 2A, minimal soft tissue ulceration, and stage 2B, presence of an orocutaneous fistula and mild soft tissue necrosis. Stage 3 includes full thickness involvement of the bone, including the inferior border. Pathological fractures may also be present. Now another classification system was grading system was given by bone toxicity according to the National Cancer Institute common terminology was given in 2009. It has 5 grading system. Grade 1 shows asymptomatic, grade 2 is symptomatic, grade 3 severe symptoms are seen, grade 4 life threatening consequences, and grade 5 leads to death. Cross references 3, the osteonecrosis of the jaw, a review and update in etiology and the treatment. These are the various bisphosphonates, the class of the bisphosphonates available. As I've already told, the medication for bisphosphonates, different classes of bisphosphonates. The first generation, there are 4 generation of bisphosphonate class. The first generation is usually non-nitrogenous, and the trade name that we get is itrodonate or clodronate. The second generation is nitrogenous usually and comes under the trade name of pamidronate, alendronate. The third generation includes opalodronate and ibendronate, and the fourth generation include the risendronate and zolendronate. This was the bisphosphonates class that are available. Now comes to the dental management of this osteoradionecrosis of the jaw before the pre-radiotherapy and after the pre-radiotherapy or a post-radiotherapy. Means pre-radiotherapy and post-radiotherapy. What are all the dental consideration we have to consider? Before radiotherapy, what we have to do is any mandibular teeth that is getting the radiation above 6000 centigrade is indicated for extraction, and the extraction should be mostly non-traumatic. The antibiotic therapy that is prescribed for almost 1 to 4 weeks, and extraction, in some authors they have told that the time duration between extraction and radiotherapy should be 2 weeks, and some various authors they recommended for at least 3 weeks time duration between extraction and radiotherapy. This was all the management we should do before radiotherapy. But after radiotherapy, we have to consider various things, like extraction should be limited in 1 to 2 teeth at a time. The extraction should be atraumatic and should be considered as a precaution, and it should be aseptic. And done with less complication. It should be the flaps that should be raised, that flap that is to be raised, it should be raised very cautiously and conservatively, and the sharp projections that should be contoured, that should be recontoured, and there should be given hyperbaric oxygen therapy. Also various alternatives of the hyperbaric oxygen therapy like ultrasound should be done. Also we can give some various prophylactic antibiotics. So this was all the dental management that should be considered. Now the conclusion is, medication related osteoradionecrosis of the jaw is a rare and a serious side effect of the anti-resorptive and anti-angiogenic medication, but potentially avoidable condition. Although the etiology is still controversial, it is understood that the dental professional plays a very important role in preventing it. The prevalence can be reduced if the patient receives prophylactic dental treatment before commencing the anti-resorptive and anti-angiogenic drugs. Also, most importantly, it is the dental professional who evaluates the patient at risk by taking a proper medical history, clinical examination to identify and manage this disease. These are my references.